Hi there, I'm Brandon Dessecker. I'm one of the fourth year general surgery residents. I'll be presenting trauma lecture, which has been prepared by Azzan Arif. He's actually one of our second years now, so we'll go ahead and get started. So initially with trauma, you're going to treat everybody the same. When they first come in through the door, blood are penetrating, you're going to do the primary survey. Your primary survey consists of 5 things that will identify injuries that are going to kill this patient within minutes. So they are, of course, the ABCs and then the D and the E, which is a little less talked about with the immediate things, especially at your level. So airway, you're going to talk to them, make sure that they can speak, make sure that there's no actual injuries to the airway itself. Make sure that they're able to control their secretions, make sure it's not full of blood. The easiest way is to have them talk. If they speak fine, clearly, normal phonation, you know your airway is patent. Moving on, if it really does not seem like it's patent, if they're having problems with it, then you're going to have to secure the airway somehow. You can either do it through an endotracheal tube or even through cricothyroidotomy, which is a little less preferred in the ER trauma bay. Whenever you're doing your airway, you need to make sure that you're maintaining cervical spine stability, and that comes into play a little bit later. But moving into the next spot, breathing. So really the main thing here is you're going to check for breath sounds. If they have bilateral breath sounds, they're good. If they have diminished on one side, then you may be dealing with a pneumothorax or a tension pneumothorax, or even a hemothorax, depending on the clinical situation. So it's very important to assess and make sure. Usually they get a pulse ox slapped on them as soon as they come into the bay. That helps as well in identifying immediate injuries. But when they come in through the bay, they typically are put on oxygen also. So those things will keep you kind of on your toes because you'll see these weird clinical situations and everything follows this order. Moving on, you get to circulation next. This is pretty straightforward. You want to make sure that you have your 2 large bore IVs, fluids, or blood, depending on the situation. And then you want to look for any active bleeding, active enlarging hematomas, hematomas at all, really. Active bleeding, spurting vessels, oozing vessels, exposed vessels. That's really your main place to look. There are a couple places you can bleed. One is on the street, one is in the chest, one is in the belly, one is in your long bones, like your femurs or your humeruses. You'll see these people come in with huge deformities to the lower extremity, which is all just hematoma and blood. And then the pelvis. If you aren't bleeding in any of those spots, then you're not bleeding enough to kill you. So, yeah, you can bleed in the head, but it's not enough to kill you, so that comes into play a little bit later. Moving on to disability, this is where you're going to do your GCS. It's very important to know. I'm sure they'll ask you at least one question in calculating it. If their GCS is less than 8, then you should intubate them because they're unable to maintain their secretions and basically keep their own airway secured. You then move on to exposure. You're going to take off all their clothes, roll them, check their back, make sure that there's nothing else going on. As far as airway is concerned, I know we talked a lot about this, but C-spine precautions are the main thing. You have to make sure that you're able to maintain while doing this. The last thing you want to do is give somebody quadriplegia just because you were trying to get it intubated. However, the intubation will save their life. So it's a tough situation. That's why it comes first. Like we were talking about earlier, if they can speak, then their airway's patent. If they are having problems, then you may need to do one of these advanced maneuvers, endotracheal intubation. As far as the airway, you're going to always make sure that you secure that airway first. Like we were talking about, it's important to maintain it, but you got to get the airway first, or otherwise they're not going to do well. You can do oral tracheal intubations, you can do nasotracheal intubations. That really just depends on the clinical situation. And then whenever you have laryngeal spasms, laryngeal trauma, pretty bad facial fractures, or even foreign bodies, it can necessitate a surgical airway, which is your cricothyroidotomy in the ER bay. As far as breathing is concerned, we kind of talked about this already. You're looking for tracheal deviation, chest expansion, oxygen level. You're also going to be feeling for crepitus fractures. They may have an open pneumothorax, which is always a possibility, and we'll talk about that a little later. Circulation is next, like we were talking about, 2 large bore IVs, fluid resuscitation, check the pulses, and then you got to put direct pressure over any obvious bleed. That's a really big movement now, especially by the American College of Surgeons and the Eastern Association of Trauma Surgeons and everything like that. So the whole thing now is stop the bleed, and they're trying to train a lot of people to do it, just random people, especially with all the recent mass casualty situations. Put pressure right on the bleed. Don't try to get proximal. Don't do anything. Just pressure on the bleed. You're going to check disability. We talked about the Glasgow Coma Scale. Here it is. You guys need to know it. Motor is the most important aspect of it in terms of diagnosing prognosis. But it adds up to 15. Know how to calculate it for your test. Like we were saying earlier, if it's less than 8, you're going to intubate these patients. Exposure, get them undressed, log roll them. Don't forget to do your actual full exam when you're doing this. You're going to maintain C-spine precautions at that time as well. So you'll see a lot of patients who come in with like these gunshot wounds. You check every crack and crevice that they have for holes. So that's very important. As far as rectal exam, that's very important in patients with like pelvic fractures to look for occult rectal trauma that would show up a couple days later and make you kind of a laughing stock of the trauma bay. Adjuncts, so you finished your primary survey, you're moving on to these important things. Chest x-ray, because that's where you can hide blood. Pelvic x-ray, because that's where you can hide blood. You can also lose quite a bit from pelvic fractures. And your FAST, which is also going to be checking your abdomen for blood. If you have obvious deformities to the lower extremity or upper extremity, you can always snap a quick film. As far as the FAST is concerned, you're focusing on 4 areas. So that's going to be your pericardium, looking for fluid, your perihepatic, perisplenic spaces, looking for fluid, and your pelvis, all looking for free fluid. It's not very good with hollow viscous injuries or even contained solid organ injuries, so we'll talk about that stuff a little bit later. So really reasons to do this would be any sort of injury to the box, which we'll talk about, I believe it's the next slide, or blunt abdominal trauma, where the patient's becoming unstable, to look for blood and check for an abdominal source, or even like a pericardial tamponade situation. So stabbing the box is a line, so it's bordered by your clavicles, your nipple lines on the lateral aspects, and then your costal margin. So any injury here, there's a very high incidence of cardiac injury, and this is just for penetrating injuries. So if you have an injury in this area, you need to do a FAST. Look at the pericardium and look for fluid. These are the areas of the FAST. This is the heart. You can see this pericardial fluid. This is assumed to be blood, especially on a trauma patient. Here you can see the liver up here, the kidney, and there's fluid in this space, which is not usually there. That's assumed to be blood. Sometimes it can be ascites though, and it can kind of trip you up a little bit. And here you have some free fluid next to a full bladder. So that could be blood, that could be urine. From a bladder rupture, it's hard to say. As far as secondary survey is concerned, you need to do a head-to-toe physical exam looking at everything. And this can really direct your clinical approach as far as getting imaging, stabilizing fractures. And it needs to be done before you move on to your further imaging. Adjuncts to your secondary survey, that's going to be your CT scan, cestogram if needed, IR and angio, your rugs, and your IVPs. IVPs aren't really used a whole lot anymore. It's mostly the rugs. And then also x-rays. We'll talk about shock here real quick. So that's hypotension, tachycardia, low output, low urine output, and these patients will be pale, they'll be cold, they'll be very anxious, and that's usually a sign that something bad's about to happen. As far as urine output's concerned, we monitor this through weight per hour. So the usual formula is you're going to have 0.5 to 1 cc's per kilogram. Hypovolemic shock, this is always assumed in a trauma patient who is in shock, is that it's secondary to hypovolemic shock. You have to rule that out first. Hemorrhage, you have a low CVP, you are going to start giving them volume replacement as quickly as possible, whether it's through crystalloid or blood, and then you need to get control. Main goal is to find the bleeding and stop the bleeding. Like we were saying, you can use a CVP as well. It's not super reliable, but in hemorrhage it's going to be low. Pericardial tamponade and tension pneumothorax is going to be high. Talking about other kinds of shock, hypovolemic is the most commonly assumed shock in the trauma patient. However, they can also get distributive shock as well, typically with their nervous system injury, which causes pronounced vasodilation that you replace through fluids and pressors, which is typically going to be your phenylephrine for that alpha stimulation. Obstructive, you can also see this can be with cardiac tamponade as well as with like a tension pneumothorax. And cardiogenic is much less common. However, sometimes you'll get people who have an MI and then crash their car, and then they come in cardiogenic shock. Most of the time, it's going to be hypovolemic. However, you may get a question about that CNS, high cervical spine injury, and like a neurogenic shock type picture. Traumatic brain injury, you diagnose this with CT scan. You can see extraaxial or intraaxial blood, mass effect, or changings with the lateral ventricles. You can get midline shift as well, and then you can see the basocisterns pretty well, which gives you a better idea. As far as patients with intracranial injury, you're going to have increased intracranial pressure from the swelling, which leads to decreased brain flow, blood flow to the brain. So your main goal is to maintain normal intracranial pressure. That can be increasing their blood pressure. It can also be head of the bed, like at 30 degrees. It can also be hypertonic saline to help decrease that pressure, or even permissive hypocapnia. So you basically hyperventilate them, decrease their CO2, which causes vasoconstriction to a certain level. Talking about certain injuries, you get the epidural hematomas, subdural hematomas, and you can get intracranial bleeds. So your epidural hematomas, that's going to be from your middle meningeal artery that gets sheared. Your subdurals are going to be from these bridging veins. And then intracerebral hematomas, there's not a whole lot that you subdural hematomas, you get those tearing of those bridging veins like we talked about. It's going to be crescent shaped, and you're going to operate if they have greater than 1 centimeter of midline shift or neurologic symptoms. Epidural hematoma, similar but not. This is going to be arterial bleeds. It's going to be that biconcave shape, and you're going to take these patients to the OR with midline shift of greater than half a centimeter, or even with neurologic symptoms. And then these are bordered by the suture lines because that's where the dura is fixed to the skull. These patients typically present with that loose interval. They get a head injury. They feel fine after getting knocked out, walking around, and then all of a sudden pass out or decompensate again. They get vomiting, typically from intracranial pressure increases. intraparenchymal hemorrhages, you can get subarachnoid, you can get intracerebral hemorrhages. Subarachnoids you don't do a whole lot for besides monitor them. If they worsen, then you can talk about doing something. Contusions, these are going to be typically on your frontal temporal pools from injuries. You get the coup, which is the side of the injury, and the contra-coup, which is the brain hitting off the other side of the skull. Diffuse axonal injury, these are going to be mostly in big acceleration, deceleration injuries. You're going to see these on MRI, and they're typically pretty poor prognosis. And then you can also have fractures. Moving on to the chest, pneumothorax. You get air that's going out of an injured lung into the pleural cavity, and tension pneumothorax is where that air goes out, and it keeps building because the lung seals itself off whenever you're expiring, so that air in the pleural cavity does not go back into the lung, and it continually expands and expands, causes compression on the superior vena cava as well as the right atrium, and leads to obstructive shock. So you can barely see this pneumothorax here. It's right along this line on the right, and this is an x-ray that never should have been got. All air, lungs crushed underneath all this air. This is a tension. You can see the mediastinum shifted to the opposite side. That's an x-ray that you shouldn't get. That should be a diagnosis clinic. Hemothorax, you can get up to 3 liters of blood in the pleural cavity. This is a massive hemothorax here. Typically, you're going to place a chest tube in these because you want to evacuate all that blood. If they put out more than 1,500 milliliters initially, so 1.5 liters, they need to go to the OR. If they put out greater than 600 cc's per hour for about 6 hours, then they also need to go to the OR to find out what's actually bleeding. Multiple times you see these patients with rib fractures. The main treatment there is pain control. As far as flail chest, that's when you get 3 ribs broken in 2 or more places. Creates an area where the bone and the muscle move independently of the rest of the wall. So when you inspire, your chest cavity expands, but that segment will actually go back in towards where the lung is, or depress. If you have patients with flail chest, you need to put in bilateral chest tubes to prevent tension pneumos. As far as pulmonary contusions are concerned, you usually get these with the flail chest. However, sometimes you can get them without and just chest trauma. That's basically a bruising of the lung. You fracture the capillaries in the lung, and over the next 48 hours, you'll see increased swelling. Their respiratory status will also decompensate somewhat, so they may need intubated a couple days. Rare situations, if you need to open the chest, you can do an ER thoracotomy. Usually through the left side is how you're going to do this. You're going to look at the left pleural space as you're going in. You're going to also go look at the heart. You're going to open the pericardium. Make sure you don't get the phrenic nerve as well, because that would be bad. And you can also clamp the aorta to help increase perfusion of the brain and the coronaries. You need to make sure, because sometimes you can bag the esophagus when you're doing that. That's a little bit above you guys, but fun to talk about. Really good videos to watch too on YouTube. Aortic rupture, these are going to be typically with your deceleration injuries. If they don't die immediately from an aortic rupture, then it's not going to kill them in the near future, like within the next hour or two. So you want to make sure that you handle all your other injuries first, and then come back to the aortic rupture once you have a stable patient. You can see a wide mediastinum on chest X-ray, and typically you're going to get a diagnose these. As far as trauma to the tracheus or the bronchus, you get subcutaneous emphysema depending on where it's at. You get a large air leak from a chest tube, one of the few indications to actually clamp a chest tube. So you put a chest tube in, and then basically all the air going in through that bronchus is going out into the pleural cavity and through the chest tube, so they're pretty much not getting any oxygen there anyways. Diagnosed with chest x-ray and a bronchoscopy, you're going to intubate these patients, and then you're typically going to do a surgical repair if it's big. Abdominal trauma, any gunshot wound to the abdomen pretty much requires an X-lap, except in very, very, very few situations. But for your purposes, if you get shot in the abdomen, you're going to the OR. If you get stabbed, you can either do like a diagnostic laparoscopy to see if the knife penetrated the peritoneum, or you can even do a local wound exploration. Now, if somebody gets stabbed and their guts are hanging out, then they got to go to the OR. As far as blunt trauma, these patients are going to go get an X-lab, typically if they have peritoneal signs. Sometimes you'll get a CT scan on somebody with blunt trauma, and in a male they'll have like free fluid, but just a trace amount, and that's concerning for like a bowel injury with like spillage of enteric contents, because males shouldn't have free fluid in the pelvis. Now females can, especially with ovarian type etiology, so just something to kind of consider. If it's bleeding, which is typically going to be with your with your solid organ injuries, that kind of depends on if they're stable or not. I think we talk about that a little bit later. So the most commonly injured organ in abdominal trauma is going to be your liver. Most commonly injured organ in blunt trauma, probably also the liver, but some places the spleen. So solid organ injuries, we'll break all this stuff down real quick. You have somebody who gets blunt trauma, and they're hemodynamically stable, you're getting a CAT scan. If they're unstable, that's a reason to do a fast. If they have free fluid and they're unstable, you're going to the OR. If you get your CAT scan, then you see these solid organ injuries. So you see, liver injuries, spleen injuries. If they're ever unstable, take them to the OR with these injuries. If they are stable, you can give patients blood up to 4 units for the liver and up to 2 units for the spleen before you take them to the OR. All these grades, they're nice to talk about, but they don't matter for you guys. All you need to know is if they're unstable with these solid organ injuries, to the OR. If they're stable, liver can take up to 4 units of packed cells. Spleen can take up to 2 units of packed cells before you have to take them to the OR. These patients are monitored in the ICU without DVT prophylaxis, bed rest, and PO. As far as the remainder of the organs, small intestine is typically injured with penetrating trauma, and that's just because there's a lot of it, and you're typically stabbed in the middle of the chest or shot in the middle of the chest. However, sometimes you can also see it with colon. Diaphragms are tough to diagnose initially. Typically, they're going to present late with a large hernia, mostly on the left side for those hernias. Retroperitoneal hematomas, they're broken down into a couple areas. Zone 1 is bordered by the medial portion of the kidney. These are your big vessels, aorta, cava. If you have a hematoma here, you have to explore it, blunt or penetrating trauma. For blunt trauma with 2 lateral portions of it, so pretty much at the kidney and more laterally, you can observe these if they're stable with blunt trauma, and then they need to be explored if they have penetrating trauma. And the similar area thing is noted for these zone 3 injuries, which is the pelvis. Now, if they're unstable, these need explored regardless of the mechanism. We talked about this already. I disagree with the retroperitoneum being a place that you can bleed out, but it is what it is. Urethral injuries. These patients are going to get Foley catheters. They're not going to get Foley catheters. You're going to diagnose these with physical exam, high-riding prostate, which means that urethra has been transected and that prostate can kind of pop back up towards the bladder. And also with blood at the urethral meatus. Do not place a Foley in these patients. They typically have concomitant pelvic fractures. You're going to do a retrograde urethrogram. You see this nice filling of the urethra all the way up into the bladder. On that one, that's normal. And down here, you see this not nice filling all the way up to the prostatic urethra, which is going to be one of the more common areas. These patients typically get a suprapubic catheter and delayed repair. They can have problems with strictures most commonly. However, they can also get like impotence and incontinence. Sometimes they need pretty big reconstructions. Bladder injuries. So you get a couple different kinds. Extraperitoneal. So that means that it's ruptured into this retroperitoneum near the rectum. doesn't really go anywhere. It's all in the retroperitoneum. They just get a Foley catheter for 10 days and things heal up on their own. The intraperitoneal rupture, so you get rupture into the actual peritoneal cavity, these patients need an operation or it'll never heal. Duodenal hematomas, these are typically going to be seen with a handlebar injury to like the upper quadrants. Compress the duodenum against the spine. These patients are typically going to get IV fluids, they're going to be monitored. You can try to feed them if you can get past the hematoma. However, if they don't improve, then you're going to take them to the OR and evacuate it. The hematoma is in the wall of the duodenum, so you actually have to open up the muscle. As far as neck trauma goes, penetrating trauma needs to go to the OR with expanding hematomas, instability, or obvious tracheal or esophageal injuries. Blunt trauma is a little bit more tricky, and then we'll get into the zone. We'll start at this area. Zone 1 is clavicles up to the cricoid. If you have any injuries here, it could be your great vessels. Very difficult to gain access to this area. You need to do an angio, you need to do a bronchoscopy and an esophagoscopy. Same situation here for zone 3, which is the angle of the mandible all the way up to the base of the skull. And that's going to be a similar situation. Carotid injuries, things like that. Unless they have an expanding hematoma, you're going to take these people for angio and also esophagoscopy, bronchoscopy, because they can get injuries to the airway and the esophagus. Zone 2 injuries, it's a little bit easier. If it violates if it violates the platysma, then they're going to the OR for exploration. These are for penetrating injuries only. We talked about this.